Assalamu alaikum. Our talk today is about differential diagnosis of bony tumors. We start with the most important imaging modality used in musculoskeletal system, which is the plain X-ray. A radiograph is the most useful examination in differentiating these lesions. It can predict the nature of the lesion above 70 to 80% of cases. It gives information about the site, nature, margin, matrix, periosteal reaction, and size of the lesion. CT scan and MRI are only helpful in selected cases, for example, to looking for subtle medullary changes, to look for intraosseous extent of the tumor, extraosseous extent of the tumor, and to distinguish between various soft tissue, also for detection of primary lesion and metastatic dissemination for staging of the disease. In this lecture, we talk about the systemic approach to bony tumors. We have many determinants in the analysis of potential bony tumors, this including morphology or margin of the bone lesion, age of the patient, zone of transition, periosteal reaction, rate of growth, pattern of cortical destruction, localization of the lesion, matrix calcification, solitary or multiple lesions, soft tissue involvement. So after we doing a plain radiograph, we have to determine this lesion either sclerotic or lytic. After that, we have to determine this is a well-defined lytic or ill-defined. Then we ask about the age of the patient, because the age is the most important in clinical clue in the differential diagnosis of bony tumors. Then we look for the location of the lesion within the skeleton, either long bones, skull, spine, or small bones of the hand and foot. Also, location of the lesion within the long bones, either diaphysis, metaphysis, or epiphysis, and axial location within the bone itself, either centric or eccentric. After that, we look for the pattern of bone destruction and bone repair in form of periosteal reaction, and whether the lesion is solitary or multiple. We start with the morphology of the lesion. First, lytic lesion. A well-defined lytic lesion with sclerotic margin generally represent a non-aggressive lesion. As we said in this example, a well-defined lytic lesion with sclerotic rim in case of non-ossifying fibroma. Most of bony tumors are well-defined osteolytic lesions, sometimes referred to as papillary lesions when there is an expansion of the cortex. So the differential diagnosis for this expanding lesion or papillary lesion is follow the mnemonic rignomachic, which is include the fibrous dysplasia, enchondroma, giant cell tumor, non-ossifying fibroma, osteoblastoma, multiple myeloma, aneurysmal bone cyst, simple bone cyst, hyperparathyroidism, infection, and chondroblastoma. An ill-defined or non-sclerotic margin represent an aggressive lesion seen in malignant tumors and locally aggressive benign lesion. The malignant bony tumors with ill-defined margin include Ewing sarcoma, osteosarcoma, leukemia, metastasis, and myeloma, while the aggressive benign locally aggressive lesion include infection, eosinophilic granuloma, and locally aggressive giant cell tumor. As you see here, it is an ill-defined lytic lesion in case of the aggressive type of periosteal reaction, in case of Ewing sarcoma. Another case with ill-defined lytic lesion in case of eosinophilic granuloma, which is benign lesion with locally aggressive behavior. The sclerotic lesion is well-defined always because it has a narrow zone of transition. The differential for these lesions follow the mnemonic I indicate, which is including iatrogenic, vascular, infection, neoplasm, which is our topic, is either osteoid matrix or chondroid matrix. The drugs, the inflammatory or idiopathic, congenital, autoimmune, trauma, and endocrine. Many benign osteolytic lesions that are frequently seen in younger age group may be healed and appear as a sclerotic lesion in the middle age, such as non-ossifying fibroma, eosinophilic granuloma, simple bone cyst, aneurysmal bone cyst, and chondroblastoma. This is a case of osteosarcoma. We see here an ill-defined lytic lesion. And this is case of osteomyelitis. Also, we see an ill-defined lytic lesion. But in this case, we see that there is a well-defined lytic lesion with sclerotic rim and in the early age and early staging, and after healing, it become a sclerotic lesion. The zone of transition is the most reliable indicator to determine whether an osteolytic lesion is benign or malignant. The narrow zone of transition result in sharp, well-defined border and is a sign of slow growth. As we see in these examples here, a case of non-ossifying fibroma, a case of simple bone cyst, and aneurysmal bone cyst. An ill-defined border zone of transition is a sign of aggressive growth. It's seen in malignant tumors, but also seen in tumor-like lesions, which is locally aggressive, which include the infection and eosinophilic granuloma. We see here an ill-defined lytic lesion with wide zone of transition in case of osteosarcoma, and here in case of infection, osteomyelitis, and in eosinophilic granuloma. The age is the most important clinical clue in differentiating the possible bone tumors. The primary bone tumors are seen in patients above 30, and it is rare before the age of 5 years. Above the age of 40, metastasis and multiple myeloma are the most common bone tumors. Under the age of 20, an aggressive lytic lesion is most likely to be either eosinophilic granuloma, infection, or Ewing sarcoma. According to the age of the patient and different morphology of bone lesions, we see that there is eosinophilic granuloma is the most important differential diagnosis of lytic lesion, whether well-defined or ill-defined, in the age below 20. It can be also a sclerotic when it is healed. As we said before, that healed lesion may appear sclerotic after in the middle age after healed. In the age group from 20 to 40, a giant cell tumor is important differential diagnosis. Above the age of 40, metastasis and myeloma become most common differential diagnosis. And we notice here that infection can be present in any morphology, either lytic or sclerotic, well-defined lytic or ill-defined, and involving in all age group. Pattern of bone repair in form of periosteal reaction. This reaction is non-specific because it occurs and when there is irritation to the periosteum, either by malignant tumor, benign tumor, infection, or trauma. There is no type of periosteal reaction pathognomonic, but it is indicate the aggressiveness of the lesion. We have a benign type, or that's seen in benign tumors and phalange trauma, and aggressive type. The benign type here will be solid, wavy, uniform callus formation, as seen in osteoma. And this is a lamellated type, multi-layer. There is a periodic growth here in case of Ewing sarcoma, and there is a speculated type, which is appear as a sunburst or hair on end appearance, which is represent these two types, aggressive form of aggressive lesions. And there is a quadrant triangle, which is a very aggressive form. Benign type will be, as we said, thick, well-formed, solid, wavy, uniform callus formation because chronic irritation, as in this case of osteoid osteoma. The laminated or onion peel periosteal reaction, this indicates a subperiosteal extension of the tumor or infection. The lesion have periodic growth, as in case of Ewing sarcoma. This is a multi-layered or multi-lamellated onion peel appearance. The speculated or vertical periosteal reaction is a very fast-growing lesion. Push the periosteal outward, the lesion and expand. Seen in aggressive malignant lesion, look like hair on end or sunburst. The Codman's triangle is an elevation of the periosteum away from the cortex. It indicates the limit of subperiosteal tumor in the longitudinal direction. Bone formation only occur at the tumor margin. On the left, this is example of vertical or speculated type of periosteal reaction. And on the right, there is an example of Codman triangle, and we notice the elevation of the periosteum away from the cortex. Again, this is a benign type periosteal reaction with solid type. This is a single layer periosteal reaction because of infection. This is a multi-layered in cause of Ewing sarcoma, and this is again Ewing sarcoma, but a speculated type of periosteal reaction. Fibrous dysplasia, non-ossifying fibroma, enchondroma, and simple bone cysts. These common bony lesions will not cause a periosteal reaction unless there is a fracture. So if there is no fracture and the periosteal reaction present, so we can exclude these from the differential diagnosis of the bony lesion. In this case, there is a proximal osteolytic lesion in the proximal humerus with associated with pathological fracture. This is a case of solitary bone cyst. The rate of growth, the benign and low-grade malignant neoplasm is usually intramedullary cavity underlaid because you have a slow erosion, so it's called endothelial scalloping. Whether higher grade malignant tumor is called a cortical destruction at the presentation, and there is maybe an extraosseous mass. The pattern of bone destruction, the complete destruction may be seen in high-grade malignant tumor, but also seen in locally aggressive benign tumor and infection like osteomyelitis. More uniform cortical destruction can be seen in benign and low-grade malignant lesion. The endothelial scalloping that we said before, it's one of the cortical bone that can be seen in benign lesion like fibrous dysplasia and low-grade chondrosarcoma. This is a type of cortical destruction with aggressive type in case of osteosarcoma. Whether this type is destruction with multi-layered aggressive periosteal reaction in case of Ewing sarcoma. There is a classification for bone destruction called Ludwig classification. Type 1, which is called the geographic pattern, have 3 subtypes. Type 1A is a thin sclerotic margin, it's always non-aggressive. 1B, well-defined margin, usually non-aggressive. 1C, any part of the margin is indistinct. The type 2 is moth-eaten pattern. It's difficult to define any border of the lesion at all. It represents an aggressive lesion. And you have type 3, it's called permeative type. There's multiple tiny holes that infiltrate the bone. This type is very aggressive and seen in leukemia, lymphoma, and Ewing sarcoma. This is a geographic type with sclerotic rim, and this is a geographic type, type 1B, but there is no sclerotic rim, but well-defined margin. This is a permeative type, and this is a moth-eaten type. Ballooning is a special type of cortical destruction. The destruction of endothelial cortical bone and the addition of new bone outside occur at the same rate, so resulting in expansion. The new cortex either uninterrupted or maybe focally interrupted. On the left, we see that there is an expansile lesion with regular destruction of cortical bone and peripheral layer of new bone formation. While on the right, there is a locally aggressive expansile lesion with cortical destruction and thin interrupted layer of new bone in case of giant cell tumor. There is a group of small round cell tumors, which include Ewing sarcoma, bone lymphoma, and small cell osteosarcoma. The cortex may appear normal radiographically, but there is a permeative growth throughout the Haversian channels. These tumors may be accompanied by large soft tissue mass while there is no visible of bone destruction. As in this case, the radiographs show no bone lesion and no bone destruction, but when we're doing MRI, there is an intramedullary extension and soft tissue involvement. A few notes about Haversian channels. It is a microscopic tubes that present on the peripheral cortical bone that transmit vessels and nerve from the cortical bone to supply the osteocyte within the central cancellous bone. Location of the lesion within the skeleton. First, within the skeleton, the primary tumors occur in area of the rapid growth, like distal femur, proximal tibia, and the humerus. Metastases occur with well-vascularized red bone marrow, like spine and iliac wings. Enchondroma can be seen commonly in phalanges. Hemangioma can be seen in skull and spine, chondrosarcoma within the pelvis. The tibia is the most common location for 3 uncommon tumors, which include adamentinoma, ossifying fibroma, and chondromyxoid fibroma. This is the most important differential diagnosis according to the skeleton. The site in the skeleton, we take an example for each. This is a multiple lytic lesion of the skull in case of multiple myeloma. And this is a well-defined sclerotic lesion in the left mandible in case of ameloblastoma. And this is a proximal solitary bone cyst with pathological fracture in the proximal humerus. And this is a case of distal radius aneurysmal bone cyst. And this is a case of interosseous hemangioma of distal phalanges of the fingers of the hand. This is a sclerotic metastasis within the spine. And this is a case of enchondroma within the ribs seen in CT scan. And this is a case of chondroid matrix and ill-defined lesion seen in the right iliac bone in case of chondrosarcoma. While this is a case of proximal femur osteosarcoma, we notice the osteoid matrix and the aggressive periosteal reaction. And this is the common location for adenocarcinoma within the tibial shaft. And this is a case of also osteosarcoma around the knee and the distal femur. And this is the common presentation and common looking of osteochondroma. This is a case of aneurysmal bone cyst within the talus in the foot. And this is a case of the glomus within the distal phalanx of the big toe. And location within the autonomic region of the long bones, either in the epiphysis, there is only few lesions are located in the epiphysis. So we have to focus on the lesions located in the epiphysis because it is a few. In young patients, we have two differential diagnoses, either chondroblastoma or infection. Over the age of 20, we can add a giant cell tumor. In older patient, we have a geode, which is the degenerative subchondral bone cyst, should involved in the differential diagnosis. And subarticular location is a pathognomonic for giant cell tumor. While metaphysis and epiphysis, there is a wide range of differential diagnosis, and sometimes it's difficult to determine whether the origin of the lesion from the aphysis or metaphysis, especially in large lesions. According to age, for a patient below 30, as we say, the most important differential diagnosis for epiphyseal lesion include infection and chondroblastoma. Where over the age of 40, we have, or 30, we have a giant cell tumor, infection, and geode. In addition, multiple metastasis and multiple myeloma are important differential diagnosis. Axial location within a bone, either central, eccentric, cortical, or periosteal. This is a case of central solitary bone cyst, and this is an eccentric aneurysmal bone cyst, and this is a case of osteoma within the cortex of the tibia. The matrix calcification or mineralization within the bone lesion may be important in the differential diagnosis. The mineralization of benign lesion is usually peripheral, while the malignant lesion usually central. We have a chondroid matrix, which is seen cartilaginous tumor like enchondroma and chondrosarcoma. They appear as a ring-like, popcorn, or focal stipple type. The osteoid matrix seen in osteotumor like osteodosteoma and osteosarcoma have a trabecular ossification or cloud-like or ill-defined amorphous pattern. This is a case of enchondroma with chondroid matrix, and this is a case of chondrosarcoma, which with also chondroid matrix. On the right, there is trabecular pattern of osteoid matrix in case of osteodosteoma, and this is a cloud-like type of osteoid matrix seen in sarcoma. There is a diffuse matrix mineralization in benign fibrous lesion, which appear as a crown glass appearance and seen in fibrous dysplasia. There's what is called a bony sequestrum, which is a calcified nidus seen in a bone lesion, can be seen commonly in osteomyelitis, osteodosteoma, and also seen in fibrosarcoma and eosinophilic granuloma. Polyostotic or multiple lesions, most of bone tumors are solitary lesions. Polyostotic lesion above the age of 30, the common is metastasis, multiple myeloma, and enchondroma in form of Ollier disease or Maffucci syndrome if it is associated with multiple hemangioma. This is a case of solitary enchondroma, and this is a case of multiple enchondroma, as we said in Ollier and Maffucci syndrome. The mnemonic for multiple osteolytic lesions is called FIMHI, including fibrous dysplasia, enchondroma, eosinophilic granuloma, metastasis and myeloma, hyperparathyroidism, and infection. This is a multiple lytic lesion I see here in the proximal femur. The multiple sclerotic lesion, it can be a case in case of metastasis, like from prostate, from breast cancer, or from carcinoid tumor, maybe congenital metastasis, maybe lymphoma, leukemia, or maybe healing lesions. As we said before, some of osteolytic lesion when healed become sclerotic. There is a congenital cause, metabolic trauma, or vascular. The soft tissue involvement is a sign of aggressive lesion. It means cortical breakthrough the lesion and create a soft tissue mass. Summary, the imaging feature that suggests malignant lesion include ill-defined margin, cortical bone destruction, aggressive periosteal reaction, extraosseous extension, intra-articular invasion, and neurovascular bundle affection. The feature that suggests benign lesion is well-defined margin, sclerotic rim, expanding lesion, no periosteal reaction, no extraosseous soft tissue component. We have some notes to put in mind. Most bone tumors are osteolytic. Zone of transition is the most important reliable indicator for determining whether osteolytic lesions are benign or malignant. There are benign lesions with local aggressive growth pattern, include infection and eosinophilic granuloma. Most primary bone tumors are seen in patients above 30, and in patients above 40, metastasis and multiple myeloma are the most common bone tumors. Under the age of 20, the differential diagnosis of aggressive lytic lesion, including eosinophilic granuloma, infection, and Ewing sarcoma. Infection is a common tumor mimic, are seen in any age group and may be well-defined or ill-defined osteolytic and even sclerotic. The malignant lesion never cause a benign periosteal reaction. So the periosteal reaction is important, not because it is pathognomonic or specific, but when we determine this is a benign type, we can exclude a malignant lesion. The differential of expanding or bubbly bone lesions, we follow the mnemonic phygnomatic, as we said before. And the differential for multiple osteolytic lesion, we follow the mnemonic PIMI. The multiple sclerotic lesion include tumor, healing lesions, metabolic, trauma, and vascular. This is the reference for this lecture, and thank you.